Good day and welcome to the National Bone Marrow Transplant Link, improving the quality of life and care for patients with chronic graft versus host disease. Today's conference is being recorded. At this time, I would like to turn the conference over to Ms. Jennifer Gillette. Please go ahead, ma'am.
Thank you, Luke. Yes, I'm Jennifer Gillette, and I'm the staff social worker at the National Bone Marrow Transplant Link, and I'd like to welcome everyone joining us on the call today. This month's speaker will discuss improving the quality of life and care for patients living with chronic graft versus host disease. It's our goal that today's program will inspire you and equip you with a new skill or idea as you learn how to go through this journey. A special thank you to the Leukemia and Lymphoma Society and Insight Corporation, and as well as our link partners for making this program possible today. Just so everyone knows how it's all going to go, we're going to start with just a very brief introduction to the link, and then we are going to go to our first speaker, Dr. Areej El-Jawahri, and then we have Barbara Ginsberg, a survivor. Each of them will be speaking for about a quarter of the call, and then we're going to open it up for questions. So please don't be shy. We'd love to hear your questions. And then we'll wrap it up with a few points about upcoming programs and thank you. So for those who may not be familiar with the link is dedicated to helping individuals and their families from diagnosis through survivorship. We reinforce and complement medical care by providing resources, support, and education. Some of the resources we provide to help families navigate their transplant journey are our chronic graft versus host disease telephone series and webinar support. We have our caregiver webinar series, our peer support mentor program for patients, caregivers, and donors, our second birthdays recognition program, book referrals, and emotional support from a licensed social worker. We also provide a variety of other educational and support opportunities, such as the call you are on today. Please feel free to reach out if you're interested in any of our services. Before we begin the program today, I'd like to review just a couple quick housekeeping items. One, due to a limited amount of time, the facilitator might need to cut things a little short if questions go on too long. We also ask that you only ask one question at a time. You can always get back in line if there's time on the call to ask another one. If we run out of time, you're also able to email me, and we will do our best to answer those questions. Please refrain from any judgmental statements towards fellow participants, respecting that everyone handles this experience in their own unique way. And please know that the information provided in this program is meant to stimulate conversation with your own healthcare provider and is not meant to replace your individualized medical plan. So now on to the educational part of our program. We are excited and honored to introduce you to our first speaker today, Dr. Areej El-Jawahri. She is an assistant professor of medicine at Harvard Medical School and the director of the Bone Marrow Transplant Survivorship Program at the Massachusetts General Hospital and associate director of Massachusetts General Hospital Cancer Center Survivorship Program. Dr. El-Jawahri's research focuses on improving the quality of life and care for patients with the hematologic malignancies and their families and addressing their palliative and supportive care and survivorship needs. So thank you so much for joining us today.
Thank you so much for having me. Appreciate it, Jennifer. I want to start by just giving you guys a little bit of an outline of what I will be speaking about. I want us to start by talking about some of the unmet needs that patients living with chronic graft versus host disease experience. These needs are going to highlight that a lot of the things that people are experiencing are shared in common and are important to talk about together. I'll then segue into talking about barriers at addressing the needs of patients living with chronic graft versus host disease, and then shift to talking about some of the supportive care interventions we're testing out here at Mass General and nationally to try to help patients cope most effectively with what they're dealing with. I want to start with a story because I do think that, we the story, there are common themes that will come across that we all, as patients and often, caregivers are on the phone, this story is likely going to resonate with you and your experience. I'll tell you about a patient of mine. Stephanie is a 29-year-old woman who was actually diagnosed with acute myeloid leukemia when she was 2 months pregnant. It was her first pregnancy. Unfortunately, she had a spontaneous termination of pregnancy as a result of her disease. And, Stephanie describes the initial diagnosis experience of sort of feeling a little bit under the weather initially, maybe a little bit of fatigue, and then going to see her primary care doctor who said, "Oh, you're probably okay." And at 7 o'clock in the evening, she got a phone call saying, "Hey, you have abnormal blood counts, you probably have leukemia, you need to go to the hospital right away, and this is potentially life-threatening, and you need to be admitted to the hospital." And Stephanie found out that she had to be in the hospital for the next 4 to 6 weeks. She received intensive chemotherapy and had a lot of side effects from it, including nausea and not feeling well and having some mouth sores and diarrhea. And then she was told at the end of this very long hospitalization that this was just the beginning of her journey. And she was told that she had what we call NPM1 mutated AML, which means that she has a favorable disease. So her chance of being cured of her AML was actually fairly high. With chemo alone, her chance of being cured was about 60%. And she was told that her chance of being cured with transplant was closer to 80%. And, Stephanie's young and otherwise healthy and wanted to really kind of maximize her chance of a cure and decided to go through a transplant from her brother. Her transplant course had, also side effects that you'd expect from chemotherapy. She had nausea, vomiting, diarrhea, mucositis or mouth sores. And then she left and went home and was actually feeling relatively well the first 3 months after her hospital stay for transplant. However, at about 5 months out from transplant, she was being tapered off her immunosuppression medications, and she started to have her first symptoms of chronic graft versus host disease. Her skin got all hyperpigmented and changed in color. It was very dry and was causing her a lot of itching. She had ocular graft versus host disease, so she was having really difficult time concentrating at work and being able to see, and her eyes would get very, very dry. And she also had liver graft versus host disease, which required treatment with prednisone and came with it all the side effects of prednisone. And lastly, she had oral GVHD, so her mouth, her taste was off. She loves spicy food, and all the spicy food was causing her a lot of pain when she eats. And by our criteria, Stephanie has what we call moderate chronic graft versus host disease, so it's not even what we call severe GVHD. And I remember talking to her and her husband at the 1-year visit after transplant. And at that time, again, I didn't realize how much Stephanie was really struggling with all these symptoms. And I want to quote to you what she said to me at that time. Stephanie said, "This is just not what I imagined my life to be at this point after transplant. I didn't realize that this will be my full-time job, dealing with this graft versus host disease. I don't think I can live with this for the rest of my life. I just don't know how." And for some of you, this statement and this feeling may resonate very, very strongly, because the reality is Stephanie went into this transplant thinking this is going to cure her leukemia, get her back to her normal life, and that she would have her life back. And instead, she's dealing with this odd new entity that she heard theoretically about before transplant, but didn't really process or understand how it impacts her life. And so that brings up the question of how do we really define success after a transplant? And traditionally, most of us, and I think most of us would agree that survival and cure of leukemia is very, very, very important. And it's an important outcome for all patients, families, and clinicians. At the same time, we are learning more and more about the toll of graft versus host disease on patients' lives. And so really our transplant success outcomes need to be a little bit more refined and more evolved. And so we now think about success of transplant in terms of survival and obviously being free of the disease, but really being free of chronic graft versus host disease and having an acceptable quality of life. And the reality is we know that GVHD affects a lot of our transplant survivors, up to 70%, depending on which study you look at. 40 to 70% of patients post-transplant have graft versus host disease. We think that the incidence of chronic graft versus host disease is actually increasing. And we also know that it can affect any organ. So in Stephanie's case, we talked about her mouth, her skin, her eyes, her liver, but it could also affect the lungs, the vaginal wall, penile skin, GI tract. And it's a little bit unpredictable which one of these organs is going to affect. And it is the biggest cause of morbidity and mortality in our transplant survivors. In fact, there has been a lot of studies that show the severity of chronic graft versus host disease is associated with the quality of life impairment that people have. So the more GVHD you have, the more impaired your quality of life could be. And in fact, studies have also shown that the quality of life that patients experience with chronic GVHD is very similar with a lot of the autoimmune diseases that we see, such as multiple sclerosis and lupus and other chronic conditions. But I think one of the hardest things about GVH is that, it comes a little bit out of the blue for most people. So it is unexpected after going through a curative therapy. People go through transplant to get their life back, to cure their leukemia, to cure their lymphoma, to get really back to what life used to be like before being diagnosed. And what's hard about GVH is that it's a hard concept to explain to people prior to treatment. And the number one thing I hear from patients and families is, I didn't know it could be this bad. I didn't know this is what my life would be like. And so what's hard about this is that when you're going for something that you are thinking will cure you, and then all of a sudden you're dealing with this chronic condition that people know very little about, with very unpredictable trajectory, a lot of ups and downs, not knowing if things are going to get better or not, it's really hard to cope with that. Now, just a little bit about the severity of GVHD and the quality of life impairment that I want to highlight. We know that various components of chronic GVHD affecting the skin, affecting the eyes, affecting the lung, affecting the mouth. There have been multiple studies looking at the association between how bad this GVH affecting each organ and the quality of life impairment that patients experience. And we've learned from these studies a couple of things. One is that regardless of what kind of GVH you have, it leads to substantial impairment in patient-reported quality of life and the degree of symptoms they experience. We also know, obviously, that the severity of GVHD, as I stated earlier, correlates with how bad the quality of life is. But we also know that certain organs, when affected, have more detrimental effect on quality of life. And that includes eyes, pulmonary function, so people who feel short of breath from their GVHD, and something called myofascial involvement of graft versus host disease. So that's when it's not just the skin that's involved, but it's actually the layers underneath the skin that often cause restriction of range of motion or tightness in the skin and pain and sometimes ulceration. The other piece that's hard about GVHD is that we continue to, obviously struggle to find really good, effective new treatments for it. So people tend to initially start with systemic prednisone or steroids to treat graft versus host disease. Yet at the same time, we know that prednisone and steroids have a lot of unpleasant side effects that patients experience. So, in fact, treatments for chronic graft versus host disease also contribute to the quality of life impairment that patients experience. We did a study here at Mass General just looking at the emotional toll of graft versus host disease on patients. And basically about 30 to 40% of patients have what we consider clinically significant anxiety and depression symptoms living with this disease. So this is clearly something that impacts people both physically and emotionally. So I know I probably depressed you a little bit talking about all the unmet needs of our patients with living chronic GVHD, but we have to be thinking about what can we be doing to really help our patients and families. And in order to really talk about that, I think we need a deeper understanding of what are the issues that makes it hard for us to address the needs of patients with chronic GVHD. So I want us to talk a little bit about those barriers so that we can kind of think of effective and innovative ways to help our patients living with chronic GVHD. First, one of the important barriers to know is that, as I told you, chronic GVHD can affect many organs or different organs, and so every patient is a little bit different, and the symptom profile that patients experience is a little bit different. And so one strategy is not going to work and be effective for everyone in terms of improving their symptoms. The second thing to remember is that, chronic GVHD is still considered relatively rare, meaning, it affects a subset of patients who go through transplant. And so it's really actually hard to find the volume, a lot of patients with chronic GVHD to do in a single center. So, for example, in Mass General, where I work, it's hard to do supportive care studies that include 100, 200 patients to kind of figure out what works for patients with chronic GVHD. So as a result, we have to really work together as a community to think about ways to figure out what works for our patients and what doesn't. The third piece, which is, again, a piece that you probably all relate to, is that there are often survivors after transplant move back to closer to home, and they may or may not have a transplant center near them. And so there is distance involved in how do we reach our survivors and really be able to help them in the most effective way possible. And I would say the other big issue is that we don't have really great comprehensive survivorship programs for patients with chronic GVHD. So even if you have survivorship programs at the cancer center near you, they may or may not have experience with chronic GVHD, and they may not be focused on transplant survivors. And we know that our patients have unique and special needs, and just any survivorship program is not going to be able to address those needs. So with that, with those barriers in mind, I do want us to talk about some of the more exciting things that are happening in the field that I hope will ultimately really improve outcomes for our patients. And I should say, I'm focused on this talk on patients. I can do a whole other talk on the toll of this on the entire family, right? On caregivers who are caring for our patients who are living with chronic GVHD. This is an illness that affects everyone. And so just keep that in mind as we go through this, because, again, if we are saying there are not enough resources for our patients, there are probably even less resources for our caregivers who are providing the majority of care and help at home, too. So when it comes to supportive care interventions, I want us to talk about a couple of things. One is I want to talk about the potential role of palliative care for patients with chronic GVHD. Also, we'll talk about the idea of designing and developing more smart interventions, multi-component interventions that address different needs in different patients. And just segue into talking about the role of technology and what technology can help us in terms of reaching our patients. I'll start by really defining palliative care and talking about the potential benefits of palliative care for this population. So some of you may have heard of palliative care, others may not have heard of palliative care, but I want to define palliative care because sometimes people think that palliative care is the same thing as hospice, and it's really not. Palliative care is a specialized medical specialty or medical care for people facing a serious illness. It focuses on providing patients with a relief of symptoms and stress from serious illness, with the goal of improving quality of life for the patient and the family. More importantly, it's provided by a specialty-trained team of doctors, nurses, social workers, and other specialists who work together to really provide the patients with other doctors with an extra layer of support to address the supportive care needs of patients living with a serious illness. And I want to highlight that palliative care is appropriate at any age and any stage in a serious illness and can be provided along with all curative treatment that we get. So palliative care is really not hospice care, and there's a lot of misperceptions about palliative care and what it means. While hospice care or end-of-life care could be part of palliative care for those patients who are actually dying from an illness, the specialty palliative care is really focused on improving the quality of life of any patient facing serious illness. And so with that in mind, we actually conducted a study at MGH where we integrated palliative care early in the course of illness for patients going through transplant. We asked the question whether if palliative care is involved in the care of patients going through transplant, during that acute hospital stay, can they actually feel better? Can patients feel better? So we conducted a randomized study where half the patients received standard transplant care, so they saw their transplant clinicians every day, but also received a palliative care consult, so palliative care saw the patient throughout the transplant hospital stay. And the other half just received a transplant care alone without palliative care involvement. And what we found from that study is that patients receiving the palliative care intervention, so those who saw the palliative care specialist, along with their transplant team, had improvement in their quality of life, in their symptom burden, in their depression and anxiety symptoms during transplant. And just to put things into context, the rate of clinically significant depression and anxiety symptoms in this population really dropped dramatically with palliative care involvement. But what was really fascinating about this study, and I think is really worth thinking about, is that palliative care was only seeing patients during the hospital stay. They never actually followed them as an outpatient. But even up to 6 months out from transplant, we saw improvement in patients' psychological symptoms. So about 30% of patients were depressed or had clinically significant depression symptoms at 6 months out from transplant when they'd received only transplant care, compared to 14% of people who received palliative care. Patients also had dramatically less post-traumatic stress symptoms from their hospitalization. So we now know that integrating palliative care here, and again, we integrated it in the curative setting. This is not an end-of-life intervention. This was an intervention to really help patients feel better, and it did. And so the question is, what can palliative care do for patients with chronic GVHD? We know that palliative care can help manage complex symptoms. This is their bread and butter. This is what they do, and they do it well. We also know that they can help patients adapt to living with their illness. So one of the most promising areas in palliative care research is really the impact of palliative care on effective coping strategies that patients use as they live with their illness. It could potentially reduce psychological distress and the emotional toll of GVHD on patients. And I think the other piece that I want to highlight is that palliative care does a really good job of really helping patients and families deal with the uncertainty of the illness trajectory. It's really hard to live with not knowing what the future looks like, and that is a very difficult thing to live with. And I do think palliative care does a good job of addressing that. At least we know that it does in other settings. And the question is, can we really use palliative care specialists to help us manage our patients with chronic GVHD and help them feel better? The second thing I want to talk about is this idea of trying to use, one of the things that we hear often from patients when you ask, what do you think would be helpful? They often say, talking to someone who's going through this experience. So we developed this workshop for patients with chronic GVHD. It's about 5 to 6 people per group. They're all dealing with chronic GVHD. We try to choose people with similar experiences, so, maybe based on severity of GVHD. And we really have this multi-component intervention that really tries to address all the different needs of the population. We focus on coping because we know coping and resilience are really important in helping people deal with the ups and downs of this disease. We focus on behavioral strategies to help patients deal with the complexity of just the logistics of dealing with taking care of your eyes, taking care of your mouth, the skin, all the different creams and topical treatments you have to do, and really being able to manage that complex schedule along with the medications. And the way we do this is we do it in a group setting with a facilitator, with a social worker or a psychologist and a transplant doctor or nurse practitioner. And we have a discussion about this content. It's an 8-week, basically, webinar that we do with weekly sessions. So it's very intense. But what's been really amazing is really actually seeing the interaction among the group members, because it's all done over the web. But you could see people through the webinar and you can talk to them. And so part of what's amazing is that patients, one, get the chance to actually connect with other transplant survivors who are going through chronic graft versus host disease and dealing with it and learning from each other. Often patients say, I learned something about this from, somebody told me this is really helpful for muscle cramps from GVHD, for example. So these are the kind of innovative interventions that we need to be thinking about. And I'll just put a last plug in for technology and the use of technology in patients living with chronic graft versus host disease. We have to be more creative. We have to think about ways to have promising interventions get to the hands of our patients and families. We can think about telehealth or webinars or phone calls like this to kind of disseminate information, but we can also use them on a way to intervene on our patients. But we can also think about ways to use mobile apps. Everybody now has an iPhone, iPad, or something that they can use to look at content. And so one example of this, for example, for us, we've developed this app that addresses sexual dysfunction after transplant. And the app content is really geared towards patients who have gone through transplant experience, and again, it allows dissemination of something that's really potentially efficacious, but allows people the ability to use it at home. With that, I'll just end by saying I want to share two quotes. I have more quotes, but I'll send you guys the slides so you can have them. I'll end with talking about patients' experience, because I do think those are the things that we've done a qualitative study just talking to patients about how they cope with this illness. And one of the patients talks about this idea of positive reframing and talked about saying, I have always felt that if you look at the glass half empty, and I have got a lot of people I know that that's the way they operate in life, I don't want to be around them. I stay away from them now. I don't need any negativity. I want to be looking at the positive side. You make the decisions and you set your course. I also want to talk about how people talk about feeling like having some active participation in their self-care can really help them cope with this illness. So one patient said, a lot of people don't do what they're supposed to do because they get frustrated or just, I'll skip this today or whatever. You just can't do it. So you just keep going on, just like if you have a job that you didn't really enjoy, but you had to have an income, you keep going to work. This is my job. Chronic graft versus host disease is my job. And there's so many more of these powerful quotes that I'm sure will resonate with you guys. But I do think that the future looks bright. There's a lot of us who are really dedicated to developing a lot of really helpful tools for patients living with chronic GVHD. With that, I'll end here, and we'll take questions at the end.
Thank you so much, Dr. El-Jawahri. I really just appreciate your kind approach to this. I feel like you are part social worker with a doctor, but I really appreciate you joining us today. That was wonderful.
Thank you.
I also want to introduce everyone now to Barbara Ginsberg. She is our next speaker. She is a survivor of AML and had her transplant back in 2014. She's had many ups and downs with her chronic graft versus host disease, and she is here to help share what she has found helpful in managing and coping with it. She's currently on a clinical trial with Dana-Farber and is just passionate about trying to help everyone find strategies for coping. So thank you so much for joining us, Barbara.
Thank you so much for having me. And after that presentation, I'm just blown away. There's so many things that I wanted to say in between. I mean, the doctor was just right spot on there. But I'm going to try to just stick to my plan and not interject anything that she said, which I do agree with. Anyway, so yes, as I said, I'm really happy to be on this call. And I'm also happy to announce, as was said by Jennifer, that I am 5.5 years out cancer-free. I was admitted to Brigham and Women's in 2013. I was there for 4 to 5 months, and I had my stem cell transplant in February of 2014. So a little over a year had gone by, and my symptoms from GVHD started appearing from hair loss to skin to feet, to eyes, to mouth, to stomach, every single thing that the doctor mentioned, as well as probably a little more of mine. One of the traumatic ones that just sticks in my mind is my feet. I mean, there's more than just that, than the feet, but like not being able to walk, and have a normal day has been very, very difficult. Cramps, fatigue, etc. So it has limited my life, needless to say. And I've been compromised, by trying to cope and treat only the symptoms of the chronic GVHD. My hope is, I just wanted to give you a little brief story about me and how I cope, but I really want to talk to you about how you can cope. And so I just trying to see what I was going to do here. Okay, so first of all, here are just a few little things. It's like hold your head up high and get up, which may sound silly, but it's not. Meditation and yoga are two really good coping devices. You don't have to be good in yoga. You just have to do yoga, and no one cares how the downward dog comes out, but it just puts you in a state of calmness, able to tackle the next symptom that's going to come about, so that you can, just move on with your day. Like the doctor said it's like it's going to work. Like this is your job, and it is just so true. I wonder myself, like, what do I do? Everyone, what do you do every day? And it's just like, welcome to my world. So that's part of it. Now, I also said about networking. Joining in on these conference calls is amazing. I've been on several of them. Now this one, and I hope to pick up on wherever I left off. So networking, everyone's like, network. How do you network when you're home and you feel, you have all these symptoms going on and you don't really want to network? Social workers, caregivers, people, the gym, anything that will get you out, or have your caretaker get you out to try to just alleviate some of your thoughts, and positive thinking. I can't say that enough. It's hard. It's really hard. But it's something that we have to do, and that's all there is to it. So I'm sure that some of these may resonate with you. Also, I think about my mind and my body. If you can kind of put that together and do and think in a positive way. And also I found that people that are suffering, like to help people that are suffering as well. They may have strategies, they may have different techniques. I know sometimes travel is difficult. I understand that because it is for me as well, but there are phone calls and whatnot to be able to do something like that. So another coping device that you can do is get a massage, but it's not a massage that you walk in and, your toes are all pretty and everything. It's more of a massage to stimulate your system and to get it moving and whatnot. So that's one good thing that you can do. And it's so true to be around people that are positive. It's like if you have to just weed out some of your negative people or negative opportunities, just don't, just try not to associate with a lot of negativism, as you need the positive thoughts. And also, what I was also going to say is that the conferences 3 times a year are another unbelievable tool. I've gone to 3. I plan on going to the next one, which is in May. If it's okay if I say that. Meet new people, talk to the medical people. No one has the answers, but it's grouping together and it's trying to just get through day by day, if you want to say, or the new normal, which is kind of used up a little bit, but it's okay. And then the other thing that I was going to say was, the conferences are a great experience. All I can say about that go, just make yourself go. And in a way, it's like, you're surrounded by people with your same problems. But then again, it's good that you are, because you can talk freely about it and you don't have to hide. So that is just another thing that you can do. And there are classes, stretching, yoga, walking, and it sounds silly because walking, one of my most favorite things is walking, just at a different pace. And that's all you need to think about, is all just at a different pace. Don't give up. And I just really want to close with it. Deep breathing. If you just breathe in and then breathe out throughout the day, I promise you it will calm your system and it will help you. And the last is to smile. And someone said to me, "Oh yeah, right. What am I going to smile about?" Because you're here, you're alive, you're going to be okay. Someone's looking after you. So I thank you so much, and I wish you all a great journey. Namaste.
Oh, thank you, Barbara. Those were some great tips. And now we want to open up the line to those who have questions. So, Luke, if you could please explain to everyone for them how they do the questions on this call.
I'd be very happy to. Thank you. Anyone over the phone lines, if you would like to ask a question, you can signal by pressing *1 on your telephone keypad. Please note, if you're using a speakerphone, make sure to use your mute function is turned off so that your signal reaches our equipment. You will hear a voice prompt on your phone line letting you know your line is open. And please remember to introduce yourself before posing your question. One more time, you can press *1 to ask a question. And we do have our first questioner queued up. So please just listen for the prompt on your line and go ahead. Hi, questioner. Your line is open. Are you there?
Hello?
The line is open. And is it possible
how do you know? Hello?
There we are.
How do you know who is eligible for this transplant? The question, what I heard, I'm sorry, the question I heard is, how do you know if you're eligible for this transplant? Is that the question? How do you know who is, like what stage cancer would be eligible for this transplant? And my name is Robin Duquette St. Pierre. Great. Yeah, so typically for stem cell transplant or bone marrow transplant, we use it often for patients with blood cancers, and it depends on the type of blood cancer you have and a lot of different factors, how healthy you are to get a transplant, if you have any medical issues that affect your ability to get a transplant, and obviously for some diseases it's more effective than others. So it's really a decision that takes into account a lot of different things. It's not typically used to treat patients with solid tumors, so things like lung cancer, pancreatic cancer. It's often used for lymphomas, for diseases of the blood system. My son has non-Hodgkin's lymphoma, so that would be okay for him? So again, there's a lot of different treatments for non-Hodgkin's lymphoma, including chemotherapy. There's now immunotherapy, there's CAR T-cell therapy, and there's stem cell transplant. So it's really hard to know without knowing very detailed aspects. Just to give you a sense, there's about like 50 types of non-Hodgkin's lymphoma out there. So it really depends on the specific case. But if you ever have a question about transplant, obviously talk to the doctors that are taking care of him, the oncologist, whether transplant. There's also different types of transplant. There's something we call an autologous stem cell transplant where you get your own stem cells back and not donors, and so that's often also used for lymphoma. So I'd say talk to the medical team, talk to the oncologist, and if you are in doubt, you can always ask for a transplant consult where you see a doctor who specializes in transplant care. Thank you very much. Mm-hmm.
Thank you. We have our next question. Yeah, next questioner is coming through now. Please listen for the prompt on your line.
Hi, my name is Cindy, and I suffer from a lot of graft versus host of the mouth. My mouth is so dry that I can't seem to eat much at all, not even, the blandest food. So I just didn't know if you had any suggestions for that.
Yeah, of course. And I'm sorry, where are you at? Where did you have, I guess, your transplant, and where are you?
I am a transplanted fiber, and I am 10 years out, but still suffering graft versus host.
So, actually, I'm glad you said you're the Farber, because I don't know if you've had a chance to meet. There is a wonderful doctor. His name is Dr. Treister. He's okay with me saying his name.
I've had him. I have him. He's wonderful. But, kind of no more suggestions. So I just didn't know if you had any other ideas.
So you're seeing actually the biggest specialist in terms of addressing a mouth GVHD. You're probably on all the mouthwashes. He's given you all the mouthwashes before, I take it. And so, sometimes he does injections into the mouth as well, steroid injections into the mouth. The things that seem at least to be most helpful seem to be the mouthwashes. The steroid-based mouthwashes are not usually absorbed into your body. They just go into the mouth. He often uses a compound mouthwash called Gdhd. It's actually not available as a simple mouthwash. You have to actually make it. The pharmacy has to make it for you. And it's sometimes it's expensive, so it's a little bit of a battle to get insurance to cover it. But the key with these mouthwashes is that you actually really have to use them for 5 minutes at a time, and sometimes even 10 minutes if you can, as many times as you can during the day if the mouth GVHD is very bad. But just knowing that you've seen Dr. Treister, my guess is that you've actually done all of that mouth care.
Yeah.
And it's still not working, huh?
No.
Yeah, I'm so sorry. So this is what we're talking about, right? This is what's so hard about all of this is that you could do everything and you're still struggling with a lot of symptoms. And at some point in time in these situations, it actually makes sense to do systemic treatment. And so, it sounds like you're miserable, to be honest with you, just hearing your agony.
Talk about it, no, it's just, I've lost a ton of weight, and you just want to be able to eat like everybody else, and you can't eat it. You can't eat anything.
Of course. Of course, and it's really hard. So I do think it sounds like this is sort of one situation where your oral GVHD is impacting your quality of life in such a big way. And those are the situations where, often for mouth GVHD, we don't increase systemic treatment, but this is one of those situations where I would think about it, and it would be something that's worth discussing both with Dr. Treister. He doesn't regulate your systemic treatment, but he will talk to your transplant doctor about potentially going up on some of the immunosuppression medications that you take systemically, because at this point, if you've done all the topical treatment, that's really the next step in terms of what to need. And I guess the other piece is, how do we cope with some of the symptoms? And I think some of the stuff that Barbara talked about is helpful, but, it depends on who you are and what works for you. But how do we actually cope with a degree of symptoms that we may not be able to get away with completely, get rid of completely? And how do we find the foods that don't hurt as much or feel better on us? And so I wish I have a magical answer for you. I don't.
Okay, thank you.
We'll take our next question. Please listen for the prompt on your line. Your line will be open in just a moment.
Yes. My question is related to the immune suppressants. Can you all hear me, by the way?
Oh, yes. Go ahead.
Okay. I was on immune suppressants prior to being diagnosed with chronic graft versus host, and once I was, and it was graft versus host of the lungs, once I was, not only was other treatments added to my treatments and medications I was going through, the immune suppressants were increased quite substantially also. Mm-hmm. And now I'm almost 2 years out of transplant and still on that level of immune suppressants. And the question is that something that is normal or expected? I do have concern over, obviously, just like with prednisone, which they also increased additionally, is the long-term effects of the immune suppressants on myself, trying to do what I assume is combat the GVHD.
Yeah, what a great question. So, yes, so it's very common for people to really do have a lot of an increase in their immunosuppression when they're diagnosed with GVHD, and it's very common for people to still be on immunosuppression, especially if they have active GVHD up to 2 years and even longer out. Of course, everybody shares your concerns about, what do these drugs do long term. I think in general we are all working on, the field is focused on trying to reducing exposure to prednisone, because we know it has so many of the negative side effects and long-term complications. So prednisone increases your risk of cataracts, affects your bones, it reduces, bone health over time, it causes your metabolism to be off, it causes people to gain weight. So there's a lot of negative long-term side effects. So, acutely even for a couple of years, it's probably okay. But as you continue to take it, that is one of the things that we're working on, is to try to find other medications that can modulate and help the immune system and maybe suppress the immune system a little bit, but not be as difficult to tolerate long term as prednisone. And we have been very successful, so there have been a couple of new drugs as many of you may know, ibrutinib is a new drug that has been approved for graft versus host disease that's really promising, that has less of an immune suppression effect. Another exciting drug is ruxolitinib or Jakafi. That is not yet approved for chronic, but it's approved for acute GVHD, and we think has a lot of activity in the chronic GVHD, and it also doesn't suppress the immune system as much. So, yes, it's common for people to be on immunosuppression, and yes, people do need them when their immune system does act up, especially with GVHD of the lung. We definitely don't want that to get worse. So those are situations that really can be, should be managed obviously by your transplant doctor, and hopefully you're still connected with your transplant center and getting the care that you need.
So that's, you do recommend that it be the transplant doctor that takes the lead as opposed to some pulmonologist that would take the lead on chronic graft versus host of the lungs?
Yeah, so it depends. There are some pulmonologists who have expertise in chronic GVHD and can be very helpful in managing chronic graft versus host disease. But in general, go ahead.
In my experience, there's not too many.
Yeah, there aren't too many. You're absolutely right. But in my experience, it's really it's a team effort. So, our pulmonologists don't have a ton of experience with chronic GVHD, but even if I have a patient see them, we work together to try to think about treatments. But in general, yes, I do think having a transplant clinician involved is really, really helpful, because this is rare enough that a lot of pulmonologists in the community may not have enough exposure and may not know about some of the newer drugs that might be effective and helpful.
Okay. Thank you very much.
Mm-hmm.
We'll take our next questioner. You'll hear your line open in just a moment. Please go ahead.
Hi. I forgot my question. I'm just going to go ahead and hang up, and y'all pick up on somebody else. Thank you.
Oh, sorry. If you think of it, call back or send us an email.
I will. I just got listening to everybody else, and this is part of my graft versus host. I can't hold a thought for more than 5 minutes.
This is the operator. Don't worry about hanging up. I'll just make sure you're out of the question queue. You can continue to listen to the call. No need to hang up.
Thank you.
We'll take our next questioner. Please listen for the prompt on your line.
Yes, hi. My name is Lillian. And I had AML leukemia in 2015, and I had gone through stem cell transplant in 2016, and currently I am experiencing GVHD symptoms, and I'm going through photopheresis treatment. And my question is, I would really am very interested in joining the Survivorship program that you have at MGH. I live outside of Boston, and I'm just wondering how can I do that, and can I do that?
My apologies. You cut off a little bit. Do you mind repeating the last part? I couldn't hear the last part of the question.
Oh, okay. I'm interested in joining your Survivorship program at MGH, and I'm just wondering how can I do that? I live outside of Boston.
Yeah, of course. So absolutely. We just so people know, we are our Survivor. So somebody can connect you with my email address, and there's also on our website, there's an email address to email Carrie Tortora, who's our program manager, and she will forward your email to me, and we can connect you and get you in. I will say that in general, we have taken, we've focused, the program is young. We don't have a ton of resources, so we started about 2.5 years ago, and so we have been focusing exclusively on trying to get our patients up to speed in terms of addressing survivorship needs for chronic GVHD, but slowly we're starting to expand, and now we're taking case-by-case people from outside of Mass General, but our goal is to really expand it and have it available resource for everybody. So since you're on the call, you get to absolutely come in. So just go on our website and email Carrie, and I can obviously, Jen and everybody on the call has my email contact, so I'm happy to send it around.
Thank you. I appreciate it. And just one more question, if I may. Just in case, in terms of photopheresis, what your take or experience is. I've been doing photopheresis for 6 weeks now, and dealing with scleroderma.
Yeah. So photopheresis, the data on it are really mixed, but in our clinical experience, I'd say, people who stick with it, especially with scleroderma, really do benefit from it. It's slow. It's a long process before you see the light at the end of the tunnel with photopheresis. But in my experience, almost everybody that I've put on for scleroderma, who I put on ECP on photopheresis, they actually benefit. But again, we're talking about 3-6 months. If we see a response at 3 and 6 months, we get excited and we keep it longer. And so I do think it's a really effective treatment. I think it works. It seems to work best for scleroderma, but it doesn't work right away. So you have to kind of be committed for the long haul to really see the potential benefit.
Mm-hmm. Okay. Thank you. I appreciate it.
Mm-hmm.
We'll take our next question. Questioner, your line will be open in just a moment. Please go ahead.
Hi. I was diagnosed with MDS about 2 years ago and had a stem cell transplant about 18 months ago. And I wanted to just make more comments, I guess, than a question. With regard to Dr. El-Jawahri, what you said about GVHD, the uncertainty and the variability of symptoms, I think that's definitely a factor because, and that goes to another comment I had about you can handle things when you're better prepared, but then I guess on the flip side, what if you're the type of patient that doesn't want to know anything? Like, I feel like forewarned is forearmed. And so I never felt that transplant was the cure-all. And so I think that I was better able to handle the GVHD. And even with that frame of mind, when I first had my first symptoms of skin GVHD, I have skin, GI, and eye GVHD. When I thought that it was so quote unquote cured and it went away, I was like happy, and then only to find out a month later, and now it was coming back, manifested in a different way. And so now I realize that that's sort of, I guess, chronic GVHD is going to keep coming, and to be happy that it's not as bad sometimes as other times, but always expecting it to come back. And my eye similarly. At first, I didn't even recognize it to be GVHD, and then I said, oh, this is it. And then it started to get better, and I just felt like with the waxing and waning, instead of having the up and down of being elated when it resolves or improves, and then only to be devastated again when it returns, if I kind of always expect it to return, and again, this is personal for me and, obviously not for everybody, but if I always expect it to return, then I'm like, okay, this is just another episode, and I got through the last, and this one may be worse, but, this is it. This is how it's going to be, but I'm here. Instead of having the idea that this was just a one-time cure and I'm done and that's it, I'm walking away and now it's going to be vacation for the rest, for the rest, and I'll cruise along. And definitely I agree with the importance of palliative care, or at least to emphasize the survivorship part, because I think it's very important. I kept in touch with someone who actually served as a sort of like a peer support to me. And we still keep in touch, and I find that that's helped. So I can imagine that having a palliative care or support, survivorship program can provide even more services. And one last thing, I won't take up too much more time, but I agree with everything that Barbara said about the yoga, the networking, and the positive thinking, although what I said maybe not doesn't sound like positive thinking, but I think it's sort of like a kind of positive thinking where you kind of just adjust it to this as opposed to, whatever your frame of mind was before.
Well, we appreciate your feedback. It is important. Everyone handles this in their own way, but I thank you for that. On that note, Doctor, I know that sometimes we've heard from patients that, that their GVHD has resolved. About how often is it where GVHD is able to be resolved versus a long-term quality of life issue?
Yeah, it's a great question. The reality is we actually don't have great statistics on that. We think that people with more mild chronic graft versus host disease, often their disease the GVHD can resolve, but when it does, there are things that could happen that trigger it. So getting, a sunburn or spending too much time in the sun and or getting an infection. So people with mild disease tend to actually often have it resolved. People with more moderate and severe chronic GVHD probably will have a little bit of up and down, but continue to have some GVHD affecting their lives. I do want to highlight that there is a great point here that was made that I think is really important. It's about what you're talking about in terms of reframing. It's about adjusting your expectations, right? It's about adjusting what you are hoping for, what you are thinking about. It's just modulating your expectation. And that's actually, in psychology, that's a concept what we call response shift, which is something that we think we can actually facilitate by thinking about the appropriate coping strategies to use in that context. So another pitch for something called cognitive behavioral therapy that can really help people actually think about ways to response shift and adapt. So instead of thinking I'm going to run 20 miles because this is what I used to do before all of this, I enjoy a really good walk and I feel good about that. And part of that is obviously mourning some of the losses that happened before, but I do think that idea of adjusting expectations resonate with a lot of people.
Thank you. Yeah, that is a very good point. I apologize, but at this time we're going to need to conclude our call. I want to thank everyone for joining us today. If you had a question that you didn't get an opportunity to ask, we will be sending a survey out once the call is complete, and there is a question on there that asks you if you have any additional questions, or you can email myself directly. Again, my name is Jennifer Gillette, and my email is on that survey as well. Also, I want to remind everyone if they have any other questions about survivorship issues or supports available, you can contact us at 1-800-LINK, LINK-BMT, and we will do our best to help. Just so everyone knows, our survey, or I had mentioned our survey, that next month we'll be doing our next Lunch and Learn with the LINK on helping young adults and adolescents deal with a transplant. I want to thank our speakers. This was an amazing presentation, and I want to thank our LINK partners and our sponsors, and of course all of you for joining us today. I hope everyone has a great day, and thank you for being a part of the call.
Everyone, you're in a private post-conference now.
Hey. Thank you. Oh, my goodness. It could not have been a better presentation. Thank you both.
Oh, thank you.
Very comprehensive, and I mean that just so genuinely. Doctor, you are definitely an MD and psychologist at heart. That is for sure.
I'm a social worker at heart, to be honest with you. I should have gone into social work, so.
Oh, my goodness. You are so well-rounded.
Oh, thank you. You're too kind.
And the people that come to you, I am sure, are just so blessed. And Barbara, all your tips.
So kind.
Great.
This is Peggy. I just jumped into it. Thank you both so much. That was, I have to honestly say, definitely one of our best lunch and learns, and I appreciate you both so very much.
Thank you so much. Happy to help anytime.
Oh, well, better watch what you agree to. Colin, you were fantastic.
Anytime, you guys. Anytime.
Thank you.
Well, thank you all. I hope you have a great day, too, and I hope we didn't keep you too long.
You too, no problem. Have a good one.
Thank you.
Bye-bye.
Thank you, too.
Bye-bye.